Okay, we have our diagnostic case review. This is always a fun session. We want to do audience participation here, yes?
Well, welcome to the session. We're in the interest of time because we're running behind. We're going to skip the I-ELCAP file, the teaching file discussion that we'll get into tomorrow, and we'll go straight into the cases. We have several cases that we have prepared, so we welcome participation from the audience, and we welcome the panelists to discuss these interesting cases and give us their opinion on how best to proceed with them. Both Dorothy and I have prepared some cases, so go ahead, Dorothy. I leave you with your first cases.
Okay,
And
so
then-
maybe we will do just short introduction of the panelists and ourselves. So
Okay. Well, I'm Luis Seijo from La Clínica Navarra. You've seen me before. Dorothy?
I'm Doris Shaham. I'm a radiologist from Jerusalem, and I was Claudia and David's first fellow 28 years ago. Okay,
I'm Matt Cham, cardiothoracic radiologist at the University of Washington, Seattle, and I was also David and Claudia's fellow from ages ago.
Hi, I'm Ella. We met earlier today. Nice to see you all again.
My name is Mira. I was introduced myself at the earlier session. I'm coming from Zagreb, Croatia.
Hello, everybody. My name is Guillermo Gallardo. I come from just the building opposite this one. I'm a last minute emergency change. I work as a radiologist.
Hi, my name is Viola. I'm an interventional pulmonologist in South America. You will know me from this morning.
Okay, so we're going to do audience
So there.
participation. So can we have the what do you call it?
QR
The-
code.
this- The QR
QR
code,
code, yeah.
yes, the QR code up, please. Okay, so you just have to direct your cameras, so you will get,
Click on the link.
okay, everyone has it? Okay, so we can proceed. Okay, so there is a change, so Dr.
Gallardo.
Okay.
Instead of Bastarrika.
Instead of Dr. Bastarrika, the others are as listed and they introduced themselves already. So this is the testing question. So please, okay, submit your nationality.
If you remember.
Okay, so we have
What if you're a mutt?
only 10% Spaniards. and
It's going down.
nine going down, and 91% of other nationalities. So, so now we go on to our first real case, and the first topic will be malignant versus infectious or inflammatory. So this is the first case, lingular consolidation on baseline. So you can see where. How do I do it? Like this. Okay, so you can see it on the axial as well as on the coronal images. This is another case, but with the same problem. This is somewhat strange, irregular consolidation in the right lower lobe. And the first question is, what would you recommend now? So would it be 1 month low dose CT follow-up, 3 months follow-up, 1 year, FDG PET, or a pulmonary consultation? Wow. Okay, so
Yes, just see what they think.
I will ask them afterwards. I want you to do this. Okay, so we'll stop here. So 57% thought 3 months low dose follow-up, 56%. And the second most popular choice was 26% pulmonary consultation. So we'll discuss it in a moment, and then time for questions. Okay, I want to just quickly present the next case. Okay, this is I'm not presenting this case. It's I think that any radiologist or pulmonologist here will say that this is a right middle lobe pneumonia, right? And so this was a 48-year-old non-smoker, and he did have symptoms of pneumonia, and he was treated, but this consolidation did not go away. This is what it looks like on CT. And then he had the bronchoscopy, and the diagnosis was adenocarcinoma. So just to say that in the first two cases that I showed you, we only have the baseline, so we don't know what happened with them eventually, but this is a consideration. Even if it looks what we would naturally think is pneumonia, it may be lung cancer. So this is my second case. So on the left is the baseline screening. So it was from November 21. And then on the follow-up, which was on May 23, there are these new twin bad opacities, but you know, it's like a small finding, not very diffuse. This is a close-up of the twin bad opacities, and this is so the previous case was from Mount Sinai. This case is from Hadassah, from my institution. And this is, again, I'm not showing you the baseline, but it's a recent case from last month, and you can see this small area of twin bad opacities on annual screening. And so what would you recommend here? So again, 1 month, 3 months, 1 year, PET FTG, or pulmonary consultation. Okay. So we have 41% from 39% of for 3 months low dose CT, but there are also the second most popular choice is 1 year low dose CT, and then we have pulmonary consultation. Okay, now questions for the panel. So in the context of lung cancer screening, when would you recommend pulmonary consultation? And do you think that in the two cases that I showed you, would bronchoscopy be indicated? So,
Well,
yes.
For example, for the second case with the twin bud situation, I would like to know the complete medical history of the patient, because
Okay, so the patient was asymptomatic. Okay,
Okay.
I had it on the slide. So what else would you like to know?
yeah, but for example, in my country, in Latin America, generally, the twin bud pattern must be considered as very suspicious of tuberculosis, for example.
Even
And-
when it's so minimal.
Yeah, yeah.
Okay.
We have a medium prevalence. We are a medium prevalence region for TB infection, so that could be my first suspicion.
So what would you do in the context of lung cancer screening? You see these new minor twin bad opacities. So what would you do?
Well, I would like to have examination of the sputum, for example, PCR, culture for tuberculosis, and maybe Nielsen smear in the sputum. But if the patient has no symptoms, I will go for a bronchoscopy.
So you would be in favor of pulmonary consultation with that minor asymptomatic finding?
Yeah, for us, maybe for the European
Yeah.
context, for the European context, or for the North American context, it could be different. But for us, with the high population, for example, migrant population, it would be my first suspicion.
Yeah, and I think the US context is probably different with the high prevalence of small airway disease in patients who are individuals who are actively smoking cigarettes or most recently did. But with small airway disease, such a small focus, we would consider that a negative screen with lung rads. Of course, if there's patient symptomatology, that might change the picture, but in an asymptomatic patient, it would be continued screening in a year. We see these come and go all the time.
So
So you do follow up 3 months,
No,
months,
next
1
year, next
not
year.
even next year.
Negative screen.
Okay, so 1 year.
okay, so I have a question. I think I have it listed, but I have a question for you, Ella. So in Israel, we have a national pilot for lung cancer screening, and people are having the radiologists to read the CT scans have a lot of difficulty with the grade A, grade 0, so
Yeah, so grade 0 the lung rad 0 should only be used in cases where you really can't examine the lungs and you can't explain the abnormality. So if a patient, if they didn't include the whole lungs, right, that would be a callback to make sure you completed the part of the lungs that wasn't imaged. That's probably the clearest example. For infection, we would, if you had, say, a segmental or lobar pneumonia, that's what you thought it was infection, it would be a lung rad 0 because you can't clear that part of the lung from having a lung cancer in it. So it would be treat for pneumonia and then bring the patient back for a 1 month CT.
so in the first 2 cases or the first case, the 2 patients that I showed, what would you have done in this case?
I have seen, I think that those were smaller than, say, a segmental or lobar consolidation. And we've seen a number of adenocarcinomas that can look just like that, an oddly shaped area of subsegmental ground glass, which I think both of those were. So I think it would be very reasonable to first, do they have any signs or symptoms of infection? And in the absence of that, my suspicion would go up higher. And we'd probably do a short-term follow-up CT in 3 months.
Okay, and the other question is, why did you give a range? Why is it 1 to 3 months? When would you choose 1 month? When would you choose 3 months?
I don't think I can draw on any scientific series of cases to be able to say why. I think in the lung rads committee, when we redid lung rads at the end of 2022, we tried to address the concept of infection. And when should you go down? I think it's infection direction. And when should you go down? It could be a lung cancer consideration. And I think the subsegmental subsegmental and unusual shapes fall into the atypical for pneumonia category.
Okay, anyone else
So for the
from the
fir-
panel?
yeah,
Yeah.
for the first case, it looked like it was coming and going. Is that correct? Because they were 1 month apart, and the lesions that were there before disappeared.
No, it's 2 different patients.
Oh, 2 different patients.
Just
Okay,
similar finding in two different
I
patients.
see. Okay, because there are different dates also.
Right.
Okay,
There are different patients.
different patients. Okay, okay.
Well, as a pulmonologist, the first cases, I would like to follow him very closely because the pattern, if the patient has no symptoms, for me it would be very suspicious of something that is not going well. If the patient, for example, I prescribe antibiotics, and the patient continue with the an abnormality in the CT scan, I would have a very high suspicion of, for example, lung cancer or a slow resolving pneumonia, which is also not expected for these kind of patients. Tobacco smoking is a risk factor and COPD also are risk factors for slow resolving pneumonia, but and the age too. But I don't know, maybe the one which is it doesn't have the lobar pattern or the typical lobar pattern. I will also, I have
I
a,
would like to
yeah.
follow it. So you wanted to ask a question before?
I just wanted to know how many were pulmonologists versus radiologists.
Okay, so next time we'll do it like David showed
Yeah.
before.
Instead of
We will
fantasy.
ask in the beginning, how many are these, and then we can see.
But it's a good point because I think pulmonologists deal differently with these findings than radiologists. I mean, I don't want to be facetious, but we do feel very responsible clinically speaking. We have to transmit the information. And so it's hard to tell a patient, look, there's this thing, but don't worry about it. Come back in a year. And patients look at you saying, right? Yeah, that thing is worrying me. So, yeah, so we tend to, I think, perhaps do more follow-up scans than a radiologist potentially recommend.
So, yeah.
Do you think that's true in the panel?
No, in fact,
No.
when I do the CT
Okay.
scans, it's usually the exam's been done on the same day with a cluster of our pulmonary medicine physicians are seeing the patient. And so I'm interpreting it that by the time I've gotten to it, they've usually already seen it and seen the patient. And so I put in my report what I think the recommendation is going to be, and then I look at their clinic note, and we're usually very simpatico.
Really?
We're
Okay.
not.
Yeah, I do it as well.
Mito?
So,
What do you-
yeah.
I just want to give a short comment regarding the relationship between pulmonologist and the radiologist. In this case, in fact, we have few multi-layers in the same question. It is very simple to answer. In case of infection, antibiotics should be prescribed. But let's say, I don't know the situation in specific countries. In Croatia, radiologists cannot prescribe the antibiotic therapy and then say you should come after 1 month for follow-up scan. That means that this patient should be a referral to respiratory medicine or general practitioner.
Right.
Recommendations are very, let's say, very precise in this case, but it is much more different to follow the recommendations.
Yeah, I think that the consultation with the pulmonologist is not excluding from the other options. I mean, we have also go head to head with the same patient.
We would usually make the recommendation for the antibiotics and the primary care physician would order it, and then we would make sure that the follow-up scan happens.
Yeah.
So, are there, yes, please.
Mine was just the issue of the patient with the tree back.
Yes.
So I am just trying to add my words to say that just like pulmonologists in South America, yes, in my country, the best indication is infection for treatment appearance. And then also for us, most of the time, by the time we are seeing the patients, they would have been given antibiotics in the primary care already. So once you see that, your first goal is to exclude infection, commonly pulmonary tuberculosis, and then you would follow up this patient to have maybe a chest X-ray in 6 to 8 weeks. If it doesn't improve, then you know that you need to go further. Thank you.
Okay. Yes.
Great.
So,
Ah,
I was
so-
gonna ask you, I was a little confused by your answer. So the first patient with the segmental.
Subsegmental.
The subsegmental consolidation.
It wasn't even consolidation, it was ground glass. It wasn't even dense enough.
Okay, I was interpreting it as consolidation. Would you have recommended antibiotic therapy? You would. Okay,
Yes.
I was a little
Yeah.
because you said something about lobar
Yeah, it
pneumonia
was-
and so on. Yeah, I was just trying to make sure that
Yeah.
the subsegmental
Mhm.
apply the same way.
Okay,
Is there another
so,
comment?
so Mauricio? Yes.
Well, all of these options may seem reasonable, but I think we should start off by considering what is the pretest probability of one disease or the other. So we know nothing about the patient. We are just looking at the picture. We don't know how old he or she is. We don't know whether he smokes or not. So it's difficult to make recommendations under these circumstances. So I'd like to know a little bit more. As our colleague from South America said, I would consider TB first. Why? Because she lives in a country with a high incidence of TB. But maybe it's not the case for us. Thanks.
Okay, Thank you.
Only images.
Okay, I would like to move on to the next case,
And
okay?
no clinical background. Hello, welcome to radiology.
That's what you get.
Okay, so here we have another case, and I hope you can see that there are these twin bad opacities. And there is, so this is October of 2021, April 2022. Again, we see these findings. And then I'm not sure if you can see it before, but there is like a subtle cyst here. The question to you will be, okay. So, so you see, October of 21, April 22, and then September of 22. These are follow-up images. Look at them. And then the question would be, this is a close-up of the findings. And the question will be, what would you recommend? 1 month, 3 months, 1 year, needle biopsy, or pulmonary consultation?
Pulmonary.
Needle biopsy. I agree with this.
It's small.
Okay, so can we ask the panelists to explain why did you choose needle biopsy?
Well, I think the pulmonary nodule changed in 2 years, and I think it's not a good idea to continue the follow-up. I think we should have diagnosis of the lesion.
And what would you suspect? What
Well, it has emphysema too. So my first my suspicious would be neoplasm.
Okay. Anyone else has another opinion, or would you like to support this?
Guillermo wants to say something.
Yes.
No, go ahead.
I was gonna say, there is one nodule that seems to be big, dominant compared to the rest. So I think that's what everybody seems to be concerned about. It's very small in terms of doing a needle biopsy. I would refer to my pulmonary medicine colleagues who would probably want to approach it. And they have the ability to do cultures and bronchoalveolar lavage at the same time. So it may still very well be infection. The dominant nodule just makes you a little bit more concerned.
Okay. So I have a follow-up for this case.
There's a comment in the chat. Should we take it out from a thoracic surgeon in Brazil?
Also,
Right, there's a point, right? I mean, if you get a needle biopsy and it's positive, you're taking it out. If it's negative, you're highly suspicious anyway. So this is a long-standing debate as to when do you biopsy and when do you just go straight to surgery? Yeah.
Okay, why doesn't
So
it
there's some
go-
evidence in the literature that you get false negatives, right? From a needle biopsy, not in your hands, not in
Okay. Okay, so this is what happened.
So that
now
was a
it's ready for the CT guided biopsy.
Okay, so good choice. Okay. So, okay, so would any one of the panel would like to address this question? When do you suspect that we are dealing with infection versus malignancy? Yes.
What is the role of PET-CT in such nodule at that time?
That's
Because this is the rate position of when to use PET-CT and what is the side pressure that we can be sure that this is an accurate study, you know what I mean?
So PET-CT, when we have this nodule that is increasing in size, and we don't want to intervene by a biopsy, which is risky because it's small in size, right? And we don't want to take it to surgery right away. PET-CT could have a role in such situation or not? Thank you.
But the nodule is already growing, so you know it's demonstrating active behavior. Does the PET-CT add anything to that?
If the SUV is too high in its size, it's very alerting. So now we take it right away, isolate the surgery for biopsy, right? Or if we find a subtiny active lymph node, for example,
Something else.
Okay, so I think we had this discussion 2 meetings ago, right? About because in lung rats, there is an option biopsy, PET-CT versus this and that and the other. And I think we were all in the opinion that PET-CT is not very helpful, but I don't think that we have a nuclear medicine physician here with us to defend another opinion.
Well, we published our data many years ago when I first started at the Clinica with Javier, and the first article we published with the Blue Journal precisely about this. And when you have a small growing nodule, the PET-CT might actually be misleading because it's still small, so you might get a false negative, but you know it's growing, so you're suspicious anyway, like Ella said. So I really don't think that would add in that particular scenario. Once it's large, that's a different story. Maybe you're looking for adenopathy or additional findings that perhaps the CT doesn't pick up.
Right, and if it's too early, it can still be infection, right? Infectious or inflammatory. So this was my question to Ella, so we already discussed this. Okay.
So there was no needle biopsy is what somebody's asking in the chat.
No needle, no bronch, no nothing.
In that case. Right.
It was adenocarcinoma, and there was a biopsy, but only when the nodule was bigger. Actually,
So there was a needle in
this
23.
is a Mount Sinai case.
Yeah.
It was cancer. It was adenocarcinoma. Okay. So here we have so I have it in one of the next slides, but I would like to say now that in I-ELCAP, we knew about these atypical cysts more than 10 years ago, right? In 2012, there is an article which I will show you by Ali was the first author, and about the atypical cyst, but it was only introduced into lung rats in 2022. So here we have an example of stable cystic lesions. So you okay.
What would you recommend?
Okay, so what would you recommend? So we have 2022, June, and then December, and then May of 2023. So almost everyone would recommend 1 year follow-up, 80%. So anyone from the panel would like to address this?
Yes. I think this patient could need a pulmonary consultation because we need to know, sometimes we need to know what's the cause or the etiology of the pulmonary cyst. It could be, well, for me, it looks very benign. The wall is thin, is not thick. In the period of the follow-up, it has been with the same aspect in the CT scan.
So everyone thinks this? Do you think it could be cancer?
No.
Slow growing cancer could be, but 12 months should be good enough to follow it, given the slow growth.
If it's here, it's going to be cancer.
Yeah, after a year.
But this case is not so simple. You know, we don't know. In this case, we really should know some data from the medical history. Then the whole story begins. I completely agree. This patient should be referred to respiratory physician.
Even if it hasn't changed for a year?
I will be very happy to find out what is going on in this case.
So what are you?
It is not usual case. You are not looking frequently at cases like this one. In everyday practice, when you have a lot of cysts, how old is this lady?
That's the next case.
Oh, we are looking at the next case.
It's the same case.
It's the same.
I just want to be very.
It is the same one.
The other one. What?
It's the same case.
Yes, same.
Okay, so again, I can't advance. Sorry, I can't advance it. So you all think 1 year, and you think it could be something else? What, like what?
No. For me, it looks very like an old lesion in the lung, and I will follow it in 1 year.
Okay. So can I have the next slide, please?
Okay, so we can,
That one area really bothers me.
yeah, and it did go a little bit.
I think we're a little bit. And these are
The
like
previous
thicker
patient
cells.
didn't have that.
Let's see.
Diagnostic cancer.
Okay, so this is the article I was referring to. Okay, let's go to the next. So these are the new Landgrade's recommendations, and this was the lung cancer. And there was another cyst in the same, this was lung cancer.
I was just saying that, Matt, that our thoracic surgery fellows in training they come out of training and they have almost never seen a cystic lung cancer. They've gone through surgery residency, thoracic fellowship training, and they've never taken out a cystic lung nodule. That's how uncommon it is.
Is this everyone's impression in the panel, in the audience?
Not
Because
so
we've
uncommon.
seen quite a few.
Yeah.
Quite a few.
Yeah.
Same here.
You really have to be, Fred, you wanted to say something?
It's not rare.
No,
No, it's not. I agree.
But
It's just not very common.
so now we come to the question, and this is so we'll do my cases. We still have
We
time.
have 15 minutes.
We have 15 minutes. Okay, so now, this was cystic lesions, and you really have to be aware. I'm not saying that if if it doesn't change, maybe we can keep following it, but we have to know that we may be following lung cancer. And the next category is very small lesions. Okay, what to do with very small lesions? So here we have a 4-millimeter cyst with a slightly irregular wall, and the question is how to follow. 1 month, 3 months, 1 year, or CT-guided biopsy.
It's too small, 3 months.
1 year.
Baseline, yes, baseline.
Well, it says no, but I guess it's just baseline.
Ah, sorry, so it's
And it says new.
does it matter?
A little bit. Yeah, because it's more than 3 millimeters.
New, it's new.
If it's new, it's different because it's more than 3 millimeters.
Okay,
If it's
so here-
baseline, it's less than 6.
First grade,
Dimension.
4 millimeters.
millimeters.
Little, like
3.
Okay.
Mm.
Yeah, it's a tie.
It's new.
Interesting. So
Maybe the panelists need to break the tie. So half of the audience says 3 months, half says a year.
3 months. I
3
think.
months.
Yes.
3
Yeah.
months.
3 months.
No.
I would call this a Cheerio sign. This is a Cheerio sign in imaging.
Cheerio.
Yes.
Like the cereal?
Yes.
Yeah.
Cheerio.
Cheerio, like the
Yes.
cereal. Huh?
Yes.
Okay.
Yes.
So why 3 months?
It's new. It's new lesion.
So what do you think it is?
It could be a cancer. It could be a Langerhans, not the case because it's new. It could be also a meningothelial lesion. Well, there's several possibilities, I think.
Okay.
But we see lesions like this that are new that they do go away.
Right.
Little focus of infection, little bit of mucus plugging in a slightly dilated bronchus. We see lesions like this that go away as well.
So
Airway disease.
what did you think?
3 months.
3 months? So everyone in the panel for 3 months?
Yes,
No.
but I do have a question for the radiologist because, for example, when the CT scan in my country is not from the same place, you start, for example, the thick of the slides is not the same for each place. And for example, when we started the lung cancer screening program, we the people outside from our hospital, radiologists and the technicians, used to have, for example, 5 millimeters of thick, and it was very difficult for us to make them have better CT images because they insisted in having those very thick CT scans. I think this could be one of these lesions that could have been in those CT scans with very thick slides. and maybe you were not able, maybe it's not new, maybe you were not able to watch the lesion in the
Okay,
past.
but this one was new. It was the same technique before, and you really have to do thin slices, right?
Okay.
Yes.
Okay. So this is another case where another cystic lesion, and there is let's see, and you can see very subtle increase in the thickness of the wall.
That's a different
So
lesion.
it's February
Using
22
left
and
lung
the other
for-
3. And here you can see this is from someone who can do biopsies. In this case says he's sitting across from me, but not everyone can. Okay, and this is another case of biopsy through a cyst. So you can see it here, the cyst, the nodule, and the biopsy, but it's not really, I don't think that there are many people who can do it.
Yeah, it's a tough one.
Dr. Yankelevich can. Okay. So this is my last case. So this is a 71-year-old past smoker, and he presented in 2017 with this lesion. This is 2018. And this is 2019. Now, he was followed, this is the case from Israel. He was followed at another institution. And the pulmonologist he was seeing said, you don't need to follow it anymore. But for some reason, he came back 4 years later. And the pulmonologist said, okay, I think you don't need to follow it anymore, but let's do PET CT just to be on the safe side.
Slow grow lesions with PET CT is not a good idea to follow with that.
Yeah, we know, but the pulmonologist didn't know. We also thought that he doesn't need to follow it
Bad lung,
anymore.
doctor.
Okay. So this is the last one from 2019, and this is so you can see that it's very subtle, but it is growing in 2024.
Yes. Surgery.
So, and this is the FDG, so there is a low uptake, as you can see. And then the question to the audience is what will we do at this stage? 1 month, 3 months, CT-guided biopsy, bronchoscopy, or surgery?
The biopsy will just get air mostly.
So I see that surgery is gaining more and more acceptance, but CT-guided biopsy is quite close, especially after what we saw previously. Hi. Okay.
And I ask a question of the panel. Is
Yes.
this overdiagnosis? Is this what people fear, that we detect a cancer, we wait 5 years, it's still there, maybe growing a little bit, it's not FDG avid, so it's not very aggressive. You take it out, it's a cancer. Did we do the right thing, or did we put this person through a series of tests, including invasive surgery, for something that would not kill them? Is that what we call overdiagnosis?
One of the challenges is you don't know when that tumor is going to have an accelerated growth pattern. Right?
Good
Many of
answer.
these will be so slowly growing. And in a shared decision-making discussion with a patient, they may choose to not want it out because the growth rate is so slow. They may choose to come back for a follow-up instead, follow-up imaging. But some patients, knowing that it's slowly growing over that time period and that you're telling them this is cancer, are going to want it out. So I think there's a lot of conversation with the patients that's really important in cases like this that are so slow growing.
And also the patient is young. He's 71 years old. So I think the most recommended action is to take this patient to surgery.
Survival rate
Yeah.
after 5 years in these patients is 99% after treatment. So yes.
Is the expected biological pattern of the slow growth adenocarcinomas. So
Okay, so now my question to the panel is, do you think that these very, very early, very small cancers, do we have to treat them differently, or, you know, if we wait, would the prognosis be worse in these cases, even if it keeps going slowly, not if there is accelerated growth? So what do you think? And would you require additional testing prior to surgery? I see that we saw that many people from the audience did not think that we need additional testing.
Yeah, in this case, the solid component was changing, which is the most alarming part. If it was just ground glass, you could wait some more, but because the solid component's clearly growing, I think that's indication for something more invasive like surgery. Biopsy is possible too, but if it's negative, can't tell if you can really trust it when these ground glass part solid lesions are very aerated, get mostly air when you biopsy it, so you might not get an accurate result with biopsies.
And then the question is, and you addressed it in your talk before, but how can, so it's so clearly that the pulmonologists thought in the community thought that this is not cancer, then the patient would stop doing screening. So how do we make people aware of this? So, and I did want to ask, because you spoke about this in your talk this morning, but you have to invest in this, right? To organize this, to make it ongoing, because I know from my experience from our national pilot program that you do training for radiologists and people attend it and then they do something different. And so how do you keep it, you know, keep the knowledge, spread the knowledge and keep it at a high level?
Yeah, from the organization point of view, you're completely right. If you are trained once, that doesn't mean that you will follow what you learned at that time. In the meantime, things also changed. These days, it's very popular to talk about slow growing lung cancers. There is no need to perform operation. But when you face the patient with the fact that we will find out adenocarcinoma, I don't know which one of those patients will tell, okay, I will go home and come back again after 2 or 4 years. It is very tough decision-making process, and all sides should take part in their own responsibility. It is very easy to say, I will just follow up. It is, but I'm not sure that from the ethical point of view, is that really correct? But when you have a national huge program, you will face with something much more important. You will face with the waiting list. You will find out that it will be impossible to follow all those people after 3, 6, or 1 year later. At this moment, we are facing with the necessity to better tailor follow-up scans, to better personalized follow-up scans. That was message from the previous discussion regarding the biomarkers. At this moment, we are really desperately looking for reliable biomarker, either from blood or from the image. I'm pretty sure that image will be applied, image biomarker will be applied much earlier and much easier. And that is the reason why we need something else. We need the prediction score. Otherwise, you will have never-ending debate. Never-ending debate.
How do you train your teams, your pulmonologists, your radiologists? So
we have a special training for radiologists. We organize that twice a year, and respiratory physician, all kinds of them, are sitting together with thoracic surgery at the team when we will discuss the cases like this one. In fact, you pick up not the simple, not the easier cases. That is the reason why we have discussion with a lot of different ways of thinking. In a real life practice, it is much easier to work with this. Yeah.
Yeah, I would reinforce the multidisciplinary team approach to discussing a case like this, to coming to a consensus with radiology, pulmonary, thoracic surgery, all at the table, radiation oncology, all there, I think is very important in a case like this, so that the message is uniform across the specialties back to the patient. Ultimately, it's the patient's decision as to whether they want to have it out or not, based on the risk that's been conveyed and documented. I can recall a case just last week where I'm looking at this nodule that we've been following, and I'm wondering why it hasn't come out yet. And I go to look at the medical record, and they're documenting very clearly in each visit that they've discussed with the patient, this is almost certainly a lung cancer. They recommend surgery, but the patient is reluctant to, because it's been going slowly and they're not ready yet.
I will just to wrap it up. I want to tell you what happened with this case. So we decided to take it out, but since it's so small, we use a special marker system for the lungs. So here you can see this this wire, and we send the patient to the ER with to the OR with this marking in place, and okay, and the diagnosis was adenocarcinoma.
Well, I do have a comment.
Yes.
For example, as a pulmonologist, I feel that we don't get the precise or the complete information in our fellowship about how to manage lung nodules, pulmonary nodules. But I was really, when I was out of the fellowship, I was really afraid of having a patient with a pulmonary nodule. I pray every day to God because I didn't want to have the patient and to, for example, having to watch and to review 4, 5, 6 CTs in the 20 minutes appointment. That was not easy for me. But I think the pulmonary nodule clinic is the answer, because when you have a pulmonary nodule in your clinic, things go better for the institution. And for example, now my fellows in training, they go with me to the pulmonary nodule clinic, and they learn how to follow the pulmonary nodules. They go to the multidisciplinary tumor board, and almost 60% of our cases are not lung cancer, are pulmonary nodules. And that's the way they learn how to follow the nodules and be more precise in their diagnosis or their approach to.
That was a great end to the session. Thank you very much. We'll move on to the next session.